Good morning, everyone. We're just waiting for the final few people to join us, and then we will start the stakeholder reference group. So we've just got a couple more people coming through from the waiting room. Excellent. I think we are all present. Other people may join us. So this is the second session of the stakeholder reference group, and it really is a catch-up session. So you're very welcome, and maybe we have some new faces out there as well. So I am Louise Halfpenny, I'm the Director of Communications. And just to remind you what we're planning to do and how we're going to run this session, it's on Zoom. You will be on mute during the presentation. We will take questions afterwards, and we will take them via the chat function, or if you want to ask your question yourself, that's absolutely fine. We had a lot of pre-submitted questions on the session yesterday, so we did have a bit of a race to try and get through them all. We have fewer questions so far today, so it may be that we finish early or that we can take things at a slightly slower pace. And we have also noted your feedback that you would like us to explain acronyms. So the presentation does have a few acronyms, and we will make sure that we go through those in full so you know what we're talking about. The session will provide an overview of where we are in the programme with a potted history, and we will also introduce you to the timescales, to go over the decision that was made on the 1st of October around the shortlist, and to outline the next steps. I'm pleased that today we have Dwayne with us. Dwayne joined us 4 months ago now, and he is the Acute Redevelopment Programme Director. I should also say that this is being recorded and that we will upload this and yesterday's session onto our website by the end of the week. So without further ado, I'm going to hand over to Dwayne.
Thank you very much, Louise, and good morning. Sorry, I'd been muted. Good morning, everyone. Thank you very much for joining us this morning for this presentation on the acute hospital redevelopment. As many of you will know, the Trust has been working for a significant period of time to try and secure investment in our hospital facilities across West Hertfordshire. So back in the early 2000s, there was a number of health campus plans that were developed then. And at the time, it was not possible to secure either private finance or public capital for the investment on our 3 hospital sites. In 2017, we were invited to put together a so-called strategic outline case, or SOC, to look at what potential investment we could leverage over those 3 sites at Watford, at Hemel Hempstead, and at St Albans City Hospital sites. Now in 2018, we were asked to do our homework again, if you like, but what we were asked to do is show only an upper financial limit for investment. So this is the capital that we'd invest in our hospitals in line with the income that we got for our activities to treat patients at that time. So that was about 350 million. In 2019, we were delighted to be chosen as one of the new 6 hospitals in the first wave of the so-called Healthcare Investment Programme, the HIP programme, and we are in that first wave, and around 400 million was allocated to us at that point. Earlier this year, we were invited by our regulators, so that's the Department of Health and NHS England and Improvement, and I'll talk a little bit more about those in just a moment, to look at a bigger number that we could look to invest. And in particular, that would replace the main clinical block on the Watford site, the Princess Michael of Kent wing. And we were asked to look very, very specifically at whether we could do that and what the likely costs might be. And I'll come to that in just a moment. But what we do have to demonstrate, this isn't a blank check for us, what we do have to demonstrate is that we can provide value for money. So for every £1 that we invest in our hospital facilities, we have to show that we can generate £4 at least of benefit. And what I mean by benefit, I'll talk a little bit more about later. Now, on that slide, there are some acronyms, and I do apologise. I put this slide together and I get so used to these acronyms that it's just easy to put them down. NHS E&I is NHS England and Improvement. So they provide the money to clinical commissioning groups to pass to us to provide services for local people. They also have an approval role in all the investments that NHS trusts make. So they're very, very keenly involved in our redevelopment plan, and they will need to approve that before it then goes to DHSC, which is the Department of Health and Social Care in Whitehall. They will also have to approve our business cases, and HMT is Her Majesty's Treasury. Ultimately, for a scheme of this size, they also need to approve our business case. Now, in order to secure this funding, we do have to provide a business case that says we are providing the best overall value for money, that we can afford it, that the local health system can afford the consequences of the investment, and very importantly, that we can deliver this by 2025 or as soon as possible thereafter. If I could have the next slide, please. So those are our milestones. I don't intend to look back too much. What I'd rather do is look forward. As we know, on the 1st of October, we approved a short list of options, which includes 6 options for emergency care on the Watford site and 3 options at each of Hemel Hempstead and St Albans City hospitals. So we've looked at those, we've now agreed those shortlists, and now we're working on developing with our architects what that actually means in further detail on each of the sites to demonstrate that we can actually provide a hospital facility of the right scope and scale for emergency services at Watford, and also that we can provide improvements at Hemel and St Albans and can do that in the most efficient way on those sites as well. And I'll talk a little bit more about those in just a moment. We're working through that now, and by February of next year, we expect to be able to say that we have selected a preferred option for each of the 3 sites. So how the hospital would fit together on each of those 3 sites, and we intend to take that to our board and the Herts Valley CCG board in February. We look to have the outline business case completed during 2021. Now, the outline business case is the middle step in the process of finally securing the funding. But in many ways, it's sometimes the most important step, because that's really what guarantees you the capital to be invested for our redevelopment. We then move to the full business case, and that's really the final thing that actually gives us the cash and allows us to start building. But the full business case is much more about the final construction price from a builder to build the hospital, but also as an organisation, how we will manage the construction process, how we will also look to move into the new hospital and the new hospital facilities, and also our very, very detailed plans as to how we secure those benefits that we promised that we're going to put in place. So building to begin in 2023, with the new facilities open 2025, 2026. If I could have the next slide, please. So just to remind everyone that the short list of options considers emergency care at Watford. And I think it is worth saying, and just again reminding everyone, that emergency care makes up about 80+% of all the work that we do across our hospitals. So that's why we've looked very much at prioritising the emergency care aspect, because that's where the majority of our patients across West Hertfordshire access our services through emergency care. Also, that for planned care, that we're putting in place a really coherent set of options for what services will be at Hemel and St Albans, and I'll deal with those again in just a moment. But we've had to make sure as well that the process that we've been through in looking at the long list of options, so what are all the things that could have been available to us potentially to deliver these projects by the 2025-26 target, is in line with a piece of guidance called the Green Book, which is published by the Treasury. And not only do NHS trusts have to use this, but every single public sector organisation has to be able to demonstrate that they've used the Green Book appropriately and to the letter in defining how we go from a long list to a short list, and then from a short list to a preferred option. Now, within that, we had to also identify investment objectives. So what we were trying to achieve out of any planned investment, and also what we call critical success factors. So it's what does success really look like? If we're doing this, what do we really expect to get from the investment that we're putting in place? And we took those from the strategic outline case in 2019, and we did modify those based on the feedback that we had from stakeholder engagement over the last year or so, and also input from our regulators as well. Now, where we stand today is that the estimated cost of the preferred way forward is about 590 million, about 600 million at today's prices, with the majority to be expended at Watford General. As I said, it's the place where we see the highest number of patients, the more complex medical needs, and we have some of the poorest buildings on the Watford site. And then we'll be using around 50 million to invest in Hemel Hempstead and St Albans between them. If I could have the next slide, please. And this really starts to give you a flavour of how we're starting to look at the preferred way forward. We haven't defined a preferred option yet. The Treasury Green Book allows us to talk about a preferred way forward in that when we looked at that original long list to short list decision-making process and the critical success factors and investment objectives we were bringing to that, it does allow us to say we have a preferred way forward, but that can still change as a result of the more detailed analysis that we're doing now. So our preferred way forward, as I said, is for a major clinical facility on the current Watford hospital site, potentially to include some land that's currently owned by Watford Council as part of the overall Riverwell development. So it's slightly further down the hill from the existing hospital site, and that will help us to ensure that we're building the right sort of size hospital with minimum disruption to the existing services on the site. Now, as part of that, we are trying to find an option, and the way that that is configured, which would mean all our key clinical services would be delivered from a new hospital facility for emergency care on the Watford site. Now, around the Watford site, there is a redevelopment being undertaken at the moment by Watford Borough Council and its partners Kier Construction and Kier Development, called Watford Riverwell, which together with the new hospital, we're trying to integrate how those two developments work to be better than the sum of the parts. So looking at green spaces, restaurants, other retail opportunities around us, so that patients, visitors, staff and local people can have access to those as well. The preferred way forward for St Albans and Hemel involves us making improvements to urgent and planned care services at both of those sites. It's very important for us as an organisation that once we start working with a building contractor, that we minimise disruption to our services on all three sites, because there will be construction work of particular scale at all three of those sites. So we will plan it carefully to make sure that we keep clinical services operational and minimise disruption to those clinical services, but also minimise disruption to local residents, local people, staff, visitors and patients. And that will start to unfold as we go through the process over the coming 2 years. If I could have the next slide, please. So at Watford, as I said, we're looking at redeveloping about 90% of the buildings for up to 90% of the services on the site to be new. And that would be all our clinical services that are currently on the Watford site in new build accommodation. That's our aim. That's been one of our investment objectives. So that will be new facilities for all the things that you can see there: medical, surgical beds, emergency surgery, critical care, women and children's services, and a wide range of diagnostics on that site. At the Hemel site, to continue to provide urgent treatment, women and children's services, diagnostic and outpatient services, but with a focus on medical specialties and long-term conditions. That will include a new purpose-built urgent treatment centre, more diagnostics on the site, and the planned move of specialist diabetes and dermatology, bringing those together across the trust on the Hemel site and on the St Albans City Hospital site. That is currently our COVID-free site. So we plan to further enhance planned surgery there, as well as rapid access cancer diagnostics, and increasing the range of diagnostic facilities available to us, including MRI and CT, to ensure that people don't have to travel a long way for those sort of diagnostic services. And we are also on the St Albans City Hospital site in discussion with our team about how
Hello, it's Louise here. Can I just check? Can everybody still see Dwayne, because he's frozen on my screen?
has it frozen?
It just did, Dwayne, just only about 30 seconds ago. So unless you were very still, but yeah, could you just wind back just a little bit?
Sorry about that. To the Hemel Hempstead site or St Albans?
St Albans is where you were.
St Albans City Hospital is our COVID-free site. So what we're doing there already is concentrating a lot of our planned surgery there to ensure that patients who are coming into the hospital are coming in to a COVID-free site to avoid any complications after their surgery. So we intend to further enhance that, as well as provide a rapid access cancer diagnostic centre and increase the range of diagnostics available. So we'll be installing magnetic resonance imaging scanners and CT scanners to support that diagnosis and treatment on the St Albans site. If I could have the next slide, please. Thank you. Now, between now and 2020, which is only, gosh, 6 weeks away, we've got still quite a lot to do. We will continue to engage with the stakeholder reference group, particularly on transport and access. When we did the public survey at the end of August, beginning of September, improvements to transport and access to all our sites was important. It was highlighted as an issue of major importance, and we're going to start setting up a transport and access working group as part of this overall stakeholder reference engagement in the very near future. And sometime in December, we'll be looking with the architects to present to the stakeholder reference group about how the options are beginning to shape up and how ward layouts and other aspects of the redevelopment are beginning to look in the detailed work that we're doing with the architects. One of our aims is to expand this group, the stakeholder reference group, beyond those maybe who've been able to join us before, to make it more inclusive, to hear what our plans are, and to reflect the community of West Hertfordshire more broadly. We're almost on the cusp of agreeing our demand and capacity assumptions. What that means is what we think activity across our trust sites will be into the future, and what that means in terms of the number of beds, the number of outpatient rooms, the number of theatres, the number of diagnostic rooms, and so on. And we're on the cusp of agreeing that at the moment. Over the next couple of months, we'll be looking at the revenue costs. So what it costs to run a hospital of this scope and scale with the sorts of number of beds and other facilities in them, and to identify, and this is the key point about benefits, is it's not just benefits you can write a check for in terms of cash, it's also what the wider benefits are to society of this investment. And as I said earlier, for every £1 we spend, we've got to be able to demonstrate that those benefits, both in terms of cash and the benefits to wider society, are on a 4-to-1 ratio. So for every £1 we spend, we've got to show £4 of benefits as a minimum to be able to be granted the investment. So we're looking at designs at what we call 1 to 500 scale. These are on each of the sites. So these are essentially block plans which show how we could fit a hospital on the Watford site and how we could reconfigure facilities at Hemel and St Albans to meet our plans for those. Below that, we have what's called a schedule of accommodation. That's a room by room listing with the size of each room that we know will be appropriate according to the standards that we have in the NHS for space standards. And we will be agreeing those towards the end of this month and using those to recost all the capital options to make sure that they remain affordable. We've started enabling works on the multi-storey car park at Watford, and that's due to be completed in 2022. And as I indicated earlier, we'll be looking to approve the preferred estates option on all 3 sites in February. If I could have the next slide, please. In 2021, we'll be looking to complete this middle stage, this so-called outline business case, with outline plans for benefits realisation, so that cash and wider benefit to society plans, to look at how we will work with other partners and other providers across the health system, and importantly with Herts Valley CCG, looking at how we stay within the means that were given by the government, the financial envelope for the whole health system, but also how we're looking to work with partners to make sure that we develop ways in which we can stop people coming into the hospital where it isn't absolutely necessary. Then how we will plan to go to the next stage, the full business case, and also how we'll bring together our quite ambitious plans for electronic patient record, that's EPR, and wider digital plans, bringing those together with the estates options as well to provide a really fully digitally integrated hospital, which will make things a lot easier for patients, visitors and staff. And to appoint a construction partner. So that would be an organisation who would actually build our facilities for us. If I could have the next slide, please. And then in 2022, completion of the full business case. This is that final detailed document that says how we're going to realise all the benefits that we've set out previously, how we're going to realise making sure that people don't come into hospital unless it's absolutely necessary in detail, how we're going to manage ourselves while the new hospital facilities are being built, and also how we're going to manage the transition from our current facilities into the new hospital facilities. And that will take quite a lot of work ensuring that staff are really, really well aware of how the new hospital facilities will work in detail, so that when they move in on day one, they're ready to treat patients in the most efficient and effective way. We have to say, as I said before, that we can afford it and that the capital's in line with what our regulators expect. Final price from the construction partner is key to that, and is a really, really important part of the full business case, because that then gives us our final construction price to achieve our plans. Complete the MSCP, that's the multi-storey car park, apologies, on the Watford site, and to relocate pathology from the main site to another site, and that's currently under discussion at the moment, because that space that the pathology labs are in at the moment, that's where we want to build on. And if I could have the next slide, please. And that's really it. I do hope you found that helpful. And please, any questions, I'd be more than happy to answer them if I can.
Thank you very much, Dwayne. Yesterday, we didn't have time to fit in questions from Steve from Herts Valley's Hospitals. So Steve, do you want to go first? Can you should be able to unmute yourself if you're there. Okay, all yours.
Morning.
Hi, off you go.
I love the waistcoat, Dwayne.
Thank you very much. I'm known for them.
I'm doing the 2 screen thingy, so my questions are on a computer that's by the side of me, so I'm just going to move my laptop a little bit. Right, Dwayne, I have three questions and I'll try and keep them quick. Firstly, to pick up on your terminology, you've used the words preferred way forward and preferred way forward options. So can I just cut through that and ask you what the decision point is in February after you've done your designs? Is the decision to build a new block in Watford or to refurbish the PMOK building? Is that the only decision there is? Because you did say that there will be three options at Hemel Hempstead and St Albans, but from what I've seen, there are no options for anything other than the Watford site. Am I right?
In terms of how we're focusing our attention for what potential 6 options are available to us on the Watford site, those were set out in a previous presentation to SRG, and were also in our board pack. So what we're looking at is a continuum of options for providing providing accommodation for clinical services on the Watford site. So there's 6 options there. Business as usual, do minimum, all the way up to build as much as we possibly can on the site and points in between. One of which keeps the Princess Michael of Kent wing, because that's one of the options that we had in the strategic outline case, and we were asked to keep that.
So let me cut you off there, Dwayne. Sorry to be rude, but that they're not options in my view. That they're just variations of a theme. So I get to do nothing. I get to do everything. But basically, the decision is: do we build a whopping great big thing in the car park at the back, or do we refurbish what we've got? Is that it in a nutshell?
That's it in a nutshell.
Okay, that's cool. Let's just leave it there.
Terminology. You asked me about terminology, and this is very, very important. When we looked at going from long list to short list, the Treasury Green Book guidance allows us to talk about a preferred way forward. At the point of decision making in February, whichever we then choose, and it might not be what we've chosen as the preferred way forward in October, but whatever we choose as the preferred option, that's then the option that we take forward to complete the outline business case, and that's what we'll be seeking secure funding for. So I'm sorry if my terminology was not entirely clear there, but
cool.
It is absolutely clear.
Can I just make one observation from your comment yesterday? You said that I know it's difficult for people outside the health service to understand this. Now, the people that are on this call, from what I've seen, have been on all of these calls, and they're pretty knowledgeable. So I was a little bit upset, shall we say, as the way that you referred to the audience yesterday. So please be very careful in the way that you're, addressing the guys that are on this call.
But equally, Steve, I think that there are other people who are coming to this call who might not be as knowledgeable.
Absolutely, and we need to make sure that they're brought up to speed.
And I have to be respectful of that as well. Not everyone has followed this with as much diligence as you and some others have. And
absolutely,
I'm 4 months into the job, and I don't always recognise the names that come up on the screen. So I don't know if they've been part of these.
No problem.
So I wasn't trying to insult anyone. I was just trying to say that we do have terminology in the NHS that sometimes can be confusing, so that if anyone didn't understand what I was saying, then I could explain it.
Okay, thanks. Right, next question. Has the Treasury signed off the money yet? Because Helen said probably 6 weeks ago that the Treasury still hadn't signed off the money.
They don't sign off the money finally until we do the outline business case and the full business case.
No, that wasn't the question. So the Prime Minister and the Health Secretary announced HIP1 would be happening and there will be 6 hospitals built, blah, blah, blah. All of that puff and PR, which we know about. The Department of Health have directed the Trust to build something in Watford. But as far as I'm aware, the Treasury have not yet said, here is a budget which we have allocated to this hospital infrastructure programme. And that is the specific point. I don't mean has your final business case been signed off or has your outline business case been signed off. My question is, has the Treasury put a budget towards this and said to the Department of Health, you can now have this money?
Well, I'm going to go back to my original answer. They will not do that until they've got an outline business case and a full business case approved. Treasury will never do that.
Okay.
There is an allocation there. And it was re-announced as 3.7 billion, looking at 4 hospital projects that were underway. the potential for Moorfield plus the 6 HIP1s and the seed funding for the HIP2s. So
Okay.
until we have an outline business case in place, Treasury will not finally sign that money off and say that is your allocation. And that is entirely normal in the process. It's nothing
Okay.
new for HIP1 or HIP2. That's the way it's worked as long as I've been in the NHS.
Okay, thanks for clarifying that. Next question, the Health Scrutiny Committee, Hertfordshire County Council, in September were asked to, or Jane Halpin, the Integrated Care System head, was asked to provide evidence that the current preferred way forward was providing best value for money financially, or best value for public funds, because there had been no evidence presented to the Health Scrutiny Committee. You might not be aware of that, and Louise, you might not, but Jane Halpin took an action to come back to the Hertfordshire County Council Health Scrutiny Committee to provide that evidence, and that meeting is due in December. So can you tell me whether that evidence has been put together by the Trust? Because essentially that's where it will be originating.
That's correct. Sorry.
Yeah,
I will refer you back to my original presentation and say we will be at a point in January and February to be able to identify what is the what's the best value for money option.
Okay, but that's the question.
So if Jenny came to me and said, "Can you do this for December?" I would very regretfully have to say we're not in a position to do it in December.
Okay, the question wasn't about the scheme which is the preferred way forward. The question was that in arriving at the decision to conclude that the Watford site would be the answer, what was the financial assessment that was made in that process? So were the greenfield sites twice as much as redeveloping Watford, for example? And I guess you're going to say we haven't got that answer, and that will be you guys' challenge with the Hertfordshire Health Scrutiny Committee in December.
That's absolutely fine. I'm happy to appear in front of the Herts Council Scrutiny Committee to answer those questions.
Okay, cool. Final question then. Mount Vernon, on the call yesterday. Sorry?
Vernon.
Yeah, Mount Vernon. On the call yesterday, you mentioned, I think Louise said that there'll be 6 hospitals mentioned in the upcoming board papers, but there was nothing concrete so far. I've actually been working directly with the NHS England people who are working on this. And as far as they're aware, West Herts has already said, if you come and knock on our door and say, can we build a new Mount Vernon on your premises in Watford? The answer has been, yes, there's plenty of room. That wasn't quite what was mentioned yesterday. Yesterday, it was a case of you need research facilities, a high dependency unit, and that you're working on it. So can you confirm that actually now whether you have given the nod to NHS England that there is room on the site in Watford for Mount Vernon?
What we've said very, very clearly. Sorry, Louise, did you want to come in on that?
Sure, and maybe you can add. There isn't actually a lot that we can say at this point because it's not our decision, and the decision has to be made after a lot of factors have been taken into account on what is the best solution. So what's going to provide the best clinical outcome for quite a large catchment area. So we're not in a position to say where it's going to be. All we can say, and all we will say, Steve, is that we are working with Eastern North Herts and Hillingdon. Other trusts are also aware of the need to relocate those services. So we and a number of other acute trusts are following this discussion, playing our part, being ready to support, but there is no decision yet because, you know, we're just not at that point. So that's really all we can say. There are other hospitals who are also part of this discussion. So we are all ready, willing, able to be involved in the discussions because we realise that something has to change at Mount Vernon. We're probably as supportive as the next site, so we really can't add any more at this point.
I think it's a brilliant opportunity for West Herts, wherever it's positioned, and you know, putting aside whatever I might think about the site locations, looking at where Mount Vernon is now in the catchment area, it makes perfect sense to put it anywhere in the West Herts area, whether it's Watford, Hemel, St Albans, or somewhere else. So that wasn't my point. I wasn't trying to say, you know, is it in the bag already? Because I know from being on their calls that they are in a more desperate position than we are here, because they haven't got any money. They haven't even got the government saying you might be able to get some money. So
Steve, sorry to cut across, but we're over half an hour in, and I can see other people raising their hands.
Okay.
And as this is about the redevelopment and not Mount Vernon, and there are other opportunities at other fora to discuss Mount Vernon, I'd really like to go to Colin, if that's
well,
all right,
you
because
brought
he's
it
got
up.
a list of questions.
You brought it up
So-
yesterday, so that's why
Yeah.
I responded.
Thank
It'll have to
you.
go out for public consultation. That process will have to unfold.
Yeah, and it's way behind us. Okay, thanks, guys.
Thank you.
Okay, are you over to me
Colin.
now? Yes.
Yes,
Okay.
of course,
Sorry,
off you go.
just not prolong, but just continue the discussion about Mount Vernon. At meetings last week, I would certainly gain the opinion that we are the preferred partner if they do something, but they did say that they'd be looking for a standalone facility. So that's why I would ask whether there's any provision for a standalone facility, and I mean in terms of building and everything else. So that's where they are.
I'm happy to pick that up, Louise, if you like.
Sure.
I mean, my understanding is they are looking for a standalone facility on an acute site, because one of the things that Mount Vernon cancer services in particular suffer from is not having that read across to secondary and tertiary care.
Yeah.
So if there was to be a plan to relocate Mount Vernon elsewhere, and you know, until there's been a proper process put in place for public consultation around that, and a preferred site is identified, my understanding is it would be a standalone facility for cancer services, so linear accelerators, chemotherapy, possibly the beds, but they might look at sharing theatres and diagnostics potentially to get an economy of scale. But until that's been worked through in a lot more detail, we're not really going to understand how that could work. But to answer your question directly, they are looking for a discrete facility on an acute site. And one of the things that we're looking at as part of so whether potentially, if Mount Vernon were to select Watford as the site, then is there an ability to locate themselves on the Watford site? At the moment, I don't know.
Okay.
Being honest.
Yeah, okay.
Thank
It's an
you.
information process at this stage. I appreciate that.
Yeah,
Yeah.
it is. It's very, very, very early days.
Yeah.
If you wanted me to gaze into a crystal ball, I'd say we'll still be asking about Mount Vernon moving this time next year.
Thank you,
Okay.
Dwayne. Thank
Right.
you.
No.
Okay. Can I go back to a couple other questions?
Yes, Colin, off you go.
Okay. Are there plans for parent stays for the children's wards? Any discussions with organisations that like McDonald's and Rory McDonald, whatever it's called?
Yeah, there's a number of. I mean, I've worked in 2 hospitals where they've had Ronald McDonald houses.
Yes.
That's something that we haven't got to in detailed planning yet. But I'll take that as a good idea, actually.
Okay. You mentioned about the split of clinical facilities and where they'll be located. Have you any indication at this stage of which clinical facilities will not be located at Watford?
Not located at Watford. Most of the vast majority of clinical services that we currently have at the Watford site will stay there. Obviously, what we're looking to do is, as I mentioned in the presentation, is look at how we can work with our partners in the health system to make sure that people only really come into hospital when they have to. So a good example, and it was on the call yesterday, was around some ophthalmology services. Some of the simpler ophthalmology procedures are now done in the community. So I think it's about 5,000 procedures are now done in the community, and that means people don't have to come to the acute hospital site anymore. So we will be looking to see how much of those things that we can do away from the hospital site, but the majority of that emergency care will still have to be provided on the Watford site. So we are looking at moving some plant surgery. We are looking at moving some endoscopy where it's most appropriate to do that. But we're still working through that. We're still working through the absolute numbers and the absolute scale of that at the moment.
Right. Just
Does that
going
help?
back, yeah, it is helpful. One thing that Mount Vernon have done is got stats in terms of where patients live to what clinics they're attending. I wonder if we can go through that same process in determining what facilities need to be relocated.
Yes, is the answer to that question. Yes, we will be doing that.
Okay, thank you.
We're actually in process in doing that at the moment.
Thank you very much. That answers all my questions, Louise. Thank you very much indeed.
Okay,
Thank you very
Colin,
much for your time.
thank you. And I think there was a question actually about the electronic patient record, which is something that's also in our sites, because as well as our buildings, our bricks and mortar, we want to move into new buildings with a new system. So we're working very hard to bring in an electronic patient record system. And Colin had a question about, will it fit in with the national systems? Yes, it absolutely will. There are only a few providers of that service in the market, and we will definitely be going with one of those that is already running an EPR, electronic patient record, at other hospitals. So yes, it will be in line with national programmes. Now, John Dowdall, you raised some questions about construction traffic, and these were pre-submitted. So if we can, we will address those. And I think, Dwayne, you have the questions in front of you. If you wouldn't mind just doing a quick recap, that would be great. Thank you.
Will all construction vehicles entering and leaving the site be put through washing facilities to ensure that they do not bring any hazardous infections or pollutions onto or off of the site? Across all three sites, these questions are. It'll depend where they're coming from, John, as to whether we need to wash wheels as they come onto the site. If there's heavy construction work going on a particular site, wheel washing is usually done as they come off the site, so they don't track dirt and construction dust and the like onto surrounding areas. And certainly one of the last projects I worked on, we moved 90 equivalent Olympic swimming pool volumes of earth, and we had to wash all the wheels of the vehicles as they came off the site, but also wash the surrounding areas as well, the surrounding streets as well. So that's the first thing. It'll depend very much on the nature of the construction that's going on the three sites. Will construction take place 24/7, or will there be hours, days when no construction activity will take place? Normally speaking, across most local authorities in the country, they usually restrict construction activity from about 8 o'clock in the morning till about 6 in the evening, sometimes with half a day's working on a Saturday, but more often than not on a Sunday. So it won't be 24/7. It'd be very, very unusual to have construction activity going on a Sunday or a Saturday afternoon. But that will depend on the agreement that we sign around our planning consent with each local authority individually as to exactly what those working hours are. But I've never come across a hospital building site that works 24/7. And the third, in the event of construction work involving high levels of noise or vibration, such as pile driving, will there be day and time controls over such activity? Yes. Now, again, pile driving is one of those things and I'm sorry, I'm not going to try not to offend Steve, but if people aren't aware, there's two particular ways of sinking these big pieces of concrete into the ground to create the raft on which hospitals sit, the so-called piles. And there's pile driving, and that's where you get a lot of noise because literally you thwack it into the ground with essentially a blinking big hammer. Or screw auger piles, where you screw them in like you would screw a screw into a piece of wood. More often than not now, it's the latter that's used, and they're usually quite quiet, much quieter than pile driving to do screw auger piles. So, but again, we would be setting out with the local authority, with the local planning authority, very strict noise, dust and vibration parameters, and monitoring those at points in and around the site, so that, again, you know, we do protect local residents for that as well. And if there are any exceedances for a defined period of time, then we'd be telling the constructor to stop and revise their method statement for how they're going to work. So there will be day and time controls over those. Certainly, you know, we wouldn't be looking to do really noisy activities before 8 o'clock in the morning, or whenever the local authority says that we can. And I hope that's answered that question in full.
Thank you, Dwayne. We've had another couple of questions come in via the chat function, and good questions. One is about the percentage of single occupancy rooms. I know we covered this yesterday, but obviously we've got a new audience here. So if you would go through that issue, that would be great. Thank you.
Certainly happy to do that. Our current, the way we're looking at the redevelopment currently is that for intensive care, for paediatrics and maternity, those would be 100% single rooms. And that's what the evidence base that's available to us across the NHS points towards. And also in terms of cross-infection and privacy and dignity for those patient groups, 100% across those three areas, paediatrics, maternity, intensive care, is usual, and certainly in discussion with my colleagues from the other HIP1 schemes, that's the direction in which they're going. For the other wards, we're looking at the moment, sorry, excuse me, between 50 and 70% of patient rooms being in singles. The others would be in 4-bed bays. We'd never go above 4-bed bays, but 50 to 70% on the general wards, and we haven't quite landed that discussion yet. So it will be somewhere in that range. And again, that's typical of all the other hospital schemes that are being planned at the moment, and I hope that helps.
Thank you, Dwayne. And a question on pathology. So we talk about moving pathology. It's not quite that simple, because bits of pathology stay and bits will move. So if you could talk through what moving pathology really means, that would be really useful. Okay. Thank you.
So this is in a number of different dimensions. If we look at, if we split pathology into two separate bits, and they're about an equal size each, what we call hot pathology, which is those tests that have got to be done really quickly and are usually related to the emergency department and to emergency services. So we've got to keep what we call a hot lab on the site. So that means that if someone comes in to the ED and needs an urgent test, then that can be done really quickly, so that their diagnosis and treatment can start as early as possible. What we call cold pathology is that which can take a little bit longer. So maybe it's a couple of days before you would need to have a result there, particularly if it's a complex test that needs to be undertaken that takes time to generate a result. That doesn't necessarily need to be on a major hospital site. And when we look up and down the country over the last 20 years, those so-called cold pathology services have been moved away from major hospital sites. And that's the model that we're looking to adopt across West Hertfordshire and Princess Alex Harlow and Eastern North Herts NHS Trust as well, so that keep a hot lab on each site for really quick turnaround tests. And for those tests that can take a bit longer, would be off-site. We haven't yet selected a location for the off-site pathology service. So that's still a little bit up in the air in the moment, but it is important to us to have a resolution to that in the early part of next year, so that we can start undertaking those moves to allow us to free space for the major redevelopment on the Watford site. And I hope that helps.
Thank you, Dwayne. We have somebody with us who has experienced our patient pathway, where we are moving elements of service out into the community. So we've talked about only bringing people onto the site when they absolutely need to be here. And yesterday we had a question about ophthalmology, and we confirmed that specialist ophthalmology would be retained at Watford, and the buildings and the facilities would be upgraded. And we mentioned that around 5,000 procedures a year are now done at community settings. And Jenny has asked if she can share her feedback. And as we have a few moments, Jenny, if you're prepared to, please tell us. We hope it was good, but we wait to hear. So the floor is yours.
Oh, well, yeah, might dash your hopes a bit. I had an appointment, which I didn't actually ask for, but my GP referred me to the clinic that's in the shopping centre in Watford. Now, I previously had quite a lot of experience because I've had cataracts done twice, well, both cataracts done at St Albans. I can't say anything but wonderful things about the treatment there and the care there. It was fabulous. I was very uneasy about the place. I went in, apparently as I was waiting, there was something you had to go through, but there was no way of pointing that out to people as they came through the door. There were two receptionists. One was very good. The other one never put her mask on properly. She was sitting facing patients coming in, never put her mask on properly. It was always, her nose was uncovered. And at one point she was on the phone to a friend and she had it all off. There were also people walking about. I mean, it was quite a low building, so there wasn't a lot of, it was all air conditioned, so it was recycled air really. People walking about. Okay, it looked very good. They had masks on things, but they were going from one room to the other, to the other, to the other. No change of masks. So now, you know, I would have expected, like my dentist always did in Spain, change masks and gloves with every patient. That didn't seem to be happening. It wasn't very clear where people should sit because nobody told you. You know, if you're there long enough, you realise what the arrangements were, but people didn't understand. There was somebody came out of a back room, looked as if she probably had a cataract operation in this same space. Okay, there were officially social distancing, but that's not good enough when it comes to health and certainly some sort of surgery. I won't go into my experience with them because I wasn't terribly impressed, but it wasn't up to what I had had in National Health Hospitals. That's all I can say. I'm sorry, I'd like to give you some good feedback, but I haven't really got something. I felt very nervous. Yeah.
Well, good feedback is great. Less good feedback is equally important. And what Louise and I will do, we'll take that away to Herts Valley CCG because they commission that service from that provider. So it is important feedback, very, very important feedback. And we Louise and I, between us, we will take that away to our colleagues at Herts Valley CCG and make them aware of that. So thank you very, very much for doing that. And if also you wouldn't mind, if you could let either Louise or one of her colleagues have your email address, then we can make sure that we close.
Louise has it, but I will. I'll put it in writing if it helps, Louise.
Oh no, that would be really, really helpful. Thank you if you could. But
Okay.
Thank you very much for drawing that to our attention.
Thank you, Jenny. Thank you. And we have had a question about blood tests. So we are endeavouring to always make those available in the community and not to bring people onto acute sites. I don't know, Dwayne, if we've worked through any more detail on that, but pathology moving does not mean that blood tests necessarily move. We will, as Dwayne has said, always keep an element of pathology on the site. So I don't know if you have anything to add on that, Dwayne.
No, it's just really to say, you know, unless it's really, really specialist, you know, I'd possibly point to patients who are on warfarin. Then you know, the trend everywhere else has been that blood tests or bloods are taken in GP surgeries and then sent to a pathology lab for testing. And certainly the last time I had a blood test, which was a couple of years ago, that was done at my GP surgery.
Thank you. Okay, well, I can give you 5 minutes back of your day. I have no other questions coming in on the chat and I can't see anybody waving at me. So thank you everyone for your continued interest. Keep checking back onto our website. We'll put this session up and also yesterday's, and we'll be back out to you soon to talk to you about our travel and access group. So we want to involve people on the topic of travel and access. We do also want to involve you in layouts, and we'd like your views on our design principles. So quite a lot of homework coming your way if you're prepared to help us, and we'll be seeing you soon, I'm sure. Thank you, Dwayne, and thank you, everyone.
Thank you all very much for your time. Thank you.